Greetings. So, we've talked about trauma and infection when we're talking about acute monoarticular um, arthritis. Now we'll talk about the third pathology, which is crystals. Okay, so with crystals, you can have two diseases. One is gout, the other one is pseudo-gout. Well, what's the difference? Gout, uric acid crystals that are causing it. Pseudo-gout, calcium pyrophosphate crystals are causing this disease. And that's why it's called CPPD disease, calcium pyrophosphate disease. Gout and pseudo-gout. Everything is the same except the crystals are different. Oh, okay, easy to learn. So when we talked about uric acid, remember we in our anatomy and physiology talked about 80% is because of the DNA cell turnover and 20% is because of the diet, like red meat, alcohol, and that's uric acid produced and then it's excreted, right? So that's what uric acid does. So whenever one is considering gout, one thinks of uric acid levels that are higher. And they become high either because you're overproducing uric acid or you're under excreting uric acid. Okay? So when you have a lot of urate in your body because of these two, either or and. So in other words, you could have this, or you could have this and this. Okay? So again, you have a lot of urate. It migrates to the joints. When it does, it's an area where the joints don't like these crystals, and then the leukocytes, the white blood cells, come in to clean it up. That's their job. And when they do, leukocyte migration is associated with inflammation. So that's what happens with gouty arthritis. So now you have acutely an acute monoarticular inflammatory asymmetric, generally in the periphery, so peripheral arthritis. And the test favorite is first metatarsal or the big toe. That's what gets explained. It's called podagra. And Google it up and you'll see how it looks. It is not out of realm of possibilities that they're going to show you a picture, give you a history, and ask you what's going on with this patient. And it will help you recognize things in real life as well when the patients come in. Okay? So this is how the patients come in. This is what happens with gout. Okay? Now, again, what are the risk factors? Males, 30 to 45-year-old, drink alcohol, red meat, diabetes, increased lipids, hypertension, trauma surgery, which causes increased cell turnover, and drugs such as aspirin and hydrochlorothiazide. But the most important one is, hey, there's a younger male that came in with lots of alcohol and red meat and partied last night and suddenly has this inflamed first big toe. I'm thinking what? I'm thinking gout. Again, Homer Simpson. This is one of the characters in the show Simpsons. So if you can think of Homer Simpson, that's the kind of patient you're going to be. That's a prototype which will help you remember 30 to 45, likes Duff beer, eats a lot of red meat, and I'm more than sure there's diabetes, lipids, hypertension involved. So it's a good way to remember how the patients will present. Okay. Okay, so how do we diagnose it? So again, the patient comes in with uh, acute monoarticular arthritis, and it's in the peripheral area. So again, they come in with acute monoarticular arthritis, and we're not sure what's going on. They get an arthrocentesis to rule out septic, right? But turns out when we tap the joint, we get an inflammatory fluid. Okay, so that inflammatory fluid means it's less than 50,000 WBCs and it's cloudy. So that gets sent to the lab, and the lab where it looks under, one looks under the microscope, and they find there it's negative for it's negative bifringent, and it's needle-shaped crystals that one is able to see, and that gives the diagnosis of gouty arthritis. Okay, so you've got your diagnosis. Now, when they are coming in with acute gouty arthritis, uh, does one need to draw uric acid levels? Answer is no. It is unreliable in acute episodes of gout or gouty arthritis. Uric acid is unreliable in blood and urine because it's depositing in the joints. So again, uric acid high does not equal gout. Okay, or especially acute attack of gout. Acute gout is not associated with increased plasma uric acid. Okay, so again, one has to look at the joint and look at the joint fluid. What else can the provider order? Ultrasound, where small crystals may be visualized. Okay, so the patient comes in with the first attack, and now they have what? Acute gouty attack is what it is. So how does one treat it? Again, it's colchicine and NSAIDs that are used along with corticosteroids to suppress the inflammation and pain. Okay, and all this does is it just suppresses the pain. Okay, for more on these drugs, check the pharmacology section. Okay, but essentially colchicine prevents the migration of the leukocytes into the joints. NSAIDs decreases the inflammation. Corticosteroids decreases the inflammation. Okay. Okay. What happens if you don't give the drugs? They're going to be in pain for a while, but over time they're going to be fine. But you still want to treat it because it's always good to treat pain. Makes the patients comfortable. And it's important because then you can educate them on how to decrease the risk. So again, remember that 20%, hey, let's not drink alcohol, let's not eat red meat, right? Let's manage our diabetes, let's lower our lipid level, let's manage our hypertension. Hey, you're on HCTZ or aspirin, let's talk to the providers to see if we can find alternatives and discontinue those meds. Okay, and then let's follow up. We've got to get you back. Why is that? That's really important. What happens is you get a flare. That flare is like a warning sign. And then if you don't treat it, you get the next flare. So the time between the two flares is called intercritical stage. So what happens if you don't treat it and it continues is the time between the two attacks decreases, or you start to get more frequent attacks, or the intercritical phase goes down. Okay, and as that's happening and the uric acid which is in excess has more time, what it does is it does end organ damage or damage to the organ. So our goal with the follow-up is what? The goal is to prevent complications of increased uric acid. And make sure if we do that, we manage this, the good news is they're not going to have attacks and they're not going to have end organ damage. If unchecked, it goes to the next stage, which is chronic tophaceous gout. Again, more recurrent attacks. Now you start to have polyarthritis. So in other words, you start to have more joints that become involved. And this arthritis may cause those joints to degenerate. Okay? There might be tophi, which is deposition of urate in the ear pinna, elbow, okay, causing joint deformity. So this tophi is a hallmark. One may have kidney stones that are urate kidney stones. Not good. And that may cause issues with the kidney, the renal function. Lastly, it actually may cause disease of the kidneys because the urate deposits in several areas of the kidneys and causes decrease in renal function. Patient actually goes into renal failure. So that's how serious this can be if not managed. Okay? So how do we prevent, once they've got the attack, we follow up with them, how do we prevent this progression from acute gouty arthritis to chronic tophaceous gout? Okay. We say, you know what, we are going to keep your uric acids down. How do we do that? Hey, you do your part. No alcohol, no red meat. Okay, we're going to manage diabetes, hyperlipidemia, hypertension, right? We're going to do all of that stuff. And then let's see what else I can do. And the provider will say, I'm going to target and keep the uric acid less than 6. And I might give some medication. And what are the two kinds of medications? There's allopurinol and probenecid. So remember, acutely you give colchicine, but chronically you give either allopurinol, probenecid, or a combination. If they are an overproducer, you give allopurinol. If they're an underexcreter, you give probenecid. If they have kidney issues, or kidney stones. Probenecid acts on the kidneys. So in other words, in that case, you prefer more use of allopurinol. Okay, so that's sort of how we treat gout and gouty arthritis chronically. Okay, and we know what we need to target. It's the uric acid chronically. So remember, acutely we don't draw uric acid levels during the acute gouty arthritis. That doesn't help. But chronically, when we are trying to manage this disease, then yes, we do draw uric acid levels, plasma uric acid, and the provider may choose to give medications. Now you can check in the pharmacology section, and you will actually see these drugs discussed in detail. There's a rare syndrome. It's called tumor lysis syndrome. Somebody comes in with malignancy, especially leukemia or lymphoma, and they get given this chemo which kills lots of cells very, very quickly. So causes huge amounts of dumping of uric acid because that DNA now gets sliced and gives you lots and lots of urate. Again, that's not gout. That's treatment related to cancer. And so the goal is to give lots of IV fluids. So that's a separate entity. We'll talk more about it in oncology. Okay. If you don't manage this, again, we go to chronic tophaceous gout. Now they got big problems. So the goal is to prevent those patients from getting to this stage. Okay. And again, even in the later stages, it's just a question of giving them a diagnostic label. But the goal is to manage their uric acid levels. And again, acutely, colchicine, NSAID steroids, and then patient education, the lifestyle. We talked about alcohol and red meat, and then hypertension, diabetes, lipids. We got to manage that, and then consulting rheumatology. Um, if they start to get kidney disease, then nephrology and those kinds of things. And so that actually is gout. And what happens in gout. So if we were to look at nursing and nursing care, they may come in with acute gouty arthritis. So the goal is, how do we get them diagnosed and tested and treated? And then the question is to educate them on the importance of what's important, what to do, and follow up. Because the gouty arthritis, as painful as it is, will not kill them. But that uric acid over time will cause the kidneys to go bye-bye and will cause joint deformity. So we've got to get them back in so that we can get the uric acid under control with drugs like allopurinol and probenecid, and prevent nephrolithiasis, urate nephropathy, and then polyarthritis and tophaceous deposits in the patients. Okay, so that is actually gout or Homer Simpson. Now the other one is pseudo-gout. So all it is, we change from uric acid crystals to calcium pyrophosphate crystals. It is acute monoarticular inflammatory asymmetric peripheral arthritis. Remember, gout is the first MTP or the big two or podagra. However, for this one, the knee is number one. And the patient, remember, Homer Simpson was the prototype patient for gout. For pseudo-gout, Grandpa Simpson is the prototype patient. So here it's a male, but it's an elderly male generally. Okay. Or if it is a younger patient, sometimes younger patients may come in with this, but they have issues with calcium. Okay. But generally, it's elderly patients that have this disease. Okay, so Grandpa Simpson is the way to think about it versus Homer Simpson for gout. Again, they come in, the joint is tapped, and they actually have an inflammatory profile with crystals that are positive bifringent, right? And then they're rhomboid shaped. Um, Again, when we x-ray, there's calcium on the cartilage, which is called chondrocalcinosis. And again, just like with gout, we ultrasound them and we can see crystals. How do we treat it acutely? Colchicine, NSAID, steroids, same as gout. What happens if I don't treat them? They will not die. Over time, it's going to get better. They'll be uncomfortable. However, we've got to get them back, especially if they're younger patients. Because the key is what? It's the calcium. Got to make sure they don't have any other metabolic diseases which might be more serious. And we got to check for calcium, especially in younger patients. Okay? And again, how do we screen for high calcium? How we draw blood, how we interpret labs, and then how we move through hypercalcemia, something that in nephrology we'll cover under calcium disorders. So if you're interested in that, you can, after you finish this video, watch that video. So then you'll know how we follow this patient all the way through in terms from joint pain to calcium abnormality. Okay? So again, in summary, crystal disease, both gout and pseudo-gout, two kinds. Difference, uric acid crystals versus calcium pyrophosphate crystals. So that's the difference. Okay, essentially crystals depositing. If it's uric acid crystals, the pain is because of uric acid crystals versus calcium pyrophosphate crystals. Again, the first MTP or the big toe or podagra for uric acid, it's males 30 to 45, it's knee and elderly males. Homer Simpson and Grandpa Simpson. Homer and Grandpa Simpson. Okay? Right? So that's what happens. Okay? Knee with pseudo-gout or calcium pyrophosphate disease. History and physical, we've talked about it. Both will have an inflammatory profile, but when you actually take a look under the microscope, the crystals are going to be negative bifringent in one and positive bifringent in another, and their shape is going to be, one is needle shaped and the other one is rhomboid shaped. Okay. Ultrasound are both going to show crystals. Okay. Um, Acutely, how do we treat them once we diagnose it? Same way, colchicine, NSAIDs, corticosteroids if needed. And then once that's done, uric acid or gout, got to get them back in, because if we don't manage their uric acid, they progress to acute tophaceous gout, which can cause joint deformity and cause renal function issues. For pseudogout, again, especially if it's younger patients, we call them back to screen for high calcium abnormalities. Okay? And that's to prevent more complications from happening from the calcium. For chronic gout management, again, overproduction allopurinol, under excretion probenecid. Okay, and you can find more information in pharmacology related to these two drugs. And we talked about when they progress to chronic tophaceous gout and the patient has not been managed well. Again, you may see things like nephrolithiasis, urate nephropathy, tophaceous deposits in ears and elbows, polyarthritis, and that is crystal disease.